clear and the history taking is very suggestive that this patient is having MI or any other diseases, then you find the eye taking finding, then you jump into the diagnosis, but unfortunately you will miss many of the evaluation criteria. Okay, so let's go one by one and see how do we tell the rate, the rhythm, the axis, and then how to comment on abnormal findings or the diagnosis. Okay, so let's start with the rate, which is the most, simple part of the ECG. Now, before actually we go into this, I just want to revise with you. I think you know this by now from your lectures. So I just want to revise with you what is the calibration of an ECG. So when we look at an ECG, we have an x-axis and a y-axis. Now, it's very important to know that each big box, it represents on the x-axis, so on the horizontal axis, it represents 0.2 seconds, okay? It means 1/5 of a second. So, and the horizontal part is representing the voltage. So this is what we're measuring. We're measuring the electricity differences, and this is what tells us what voltage is this, and this is represents the electricity of the heart. Okay, so forget now about the voltage. I want to focus about the time. So each 5 big squares, they represent 1 second, and in a minute I will tell you why this is important. So please be aware that this calibration is very important to understand. So one big box is 0.2 seconds, so that makes 5 big boxes constituting 1 second. So how many big boxes in a minute? This is simply 5 times 60, and this equals 300 boxes. So in 1 minute, we have 300 boxes. Now, let's see what else do we have. Now, another term that we will mention now, and it's very important, to say a segment. Of course, by now you have heard of the ST segment here and there. So if you hear a word segment and interval, what is the difference between them? Now, actually, a segment, it doesn't include a wave. So if you say ST segment, it means from the end of the S wave to the start of the T wave. Okay, so it doesn't include neither the S nor the T waves. Now, if you say interval, then this actually includes a wave. Okay, this is very important, just a term that you have to know when you hear the word segment and interval. Similarly, if we apply it to the PR segment, so this is the PR segment, it doesn't include the P, it doesn't include the R, while the PR interval, it actually includes the P wave, okay? So keep this term in mind because we will be saying this term a lot. Now, following on the ST segment, I know I'm jumping to these, but I'm just giving you now the terms, then we will discuss it further. Now, keep in mind that there is something called the isoelectric line, okay? So this is the isoelectric line is simply this flat line that you see between the waves. So between the P and the Q, between the S and the T, and after the T. So this is called the isoelectric line. Now, this is my baseline, and this is where should I have all the flat lines. They should be going on the same level of this isoelectric line. Now I have something called the J point. Now the J point, it represents the ST segment. Okay, this is the first positive deflection after the S wave. Okay, so usually this should be at the same level of the isoelectric line. Now I hope this is clear. This is just an introduction for some terms to make things clear when we start analyzing and interpreting the ECG. Now, let's start the actual interpretation of the ECG. Now, the rate. We said we have 5 points we have to comment on, which are the rate, rhythm, axis, then abnormal findings, then finally the diagnosis. Now, as for the rate, to detect the rate, we have to ask first a question. Is the heart rate regular or it's irregular? Now, why are we saying this? Now, if the heart rate is regular, then we can simply divide 300. Now, why 300? Again, because this is the number of big boxes in 1 minute, and the heart rate is beats per minute. So basically, I want to get how many beats per minute. Okay, so we divide 300 over the RR interval. What is this? We will see in a minute. If it's irregular, then we will have another way that I will show you in a minute. Now let's take a look at this ECG. Of course, this is the ECG. We have 12 leads starting from lead 1, ending up with lead V6. And of course, down we have the what's called the rhythm strip. It's only lead 2. Now, if I ask you what is the rate of this patient's heart, okay? Now, first of all, before measuring the rate, we have to answer, is it regular or irregular? And how do we know that? Just go to the rhythm strip and notice the RR interval. So the difference between each QRS complex, is it the same or is it different? Okay. So what do you think, Shabab Banat? Can you see this? I put for you the golden lines. Okay. It's the same. Thank you, Jenna. Okay. So if it's the same, then I can simply say I will count the number of boxes between the RR complexes, then divide 300 over this number. Okay. So let's count it together. This is, you can take between any RR complexes because we said this is regular. Okay. So it's almost 4 if you say. Okay. So we have 3 boxes, then 1/2 here and 1/2 there. Let's say it's 4 boxes. So let's apply our rule again. So is the heart rate regular? The answer is yes. Then we apply the rule 300, which is again the number of boxes in 1 minute. Yes, thank you, Hamda. This is 300 over 4. Thank you, Horia. This is 75 beats per minute. And I will leave for you just a quick mnemonic. So if it's 1 box, then this is 300, 2 boxes, 150, 3 boxes, 300. You can, it's just a simple mathematical, operation, or you can just memorize these numbers to make you fast in the exams. Okay. Now let's take a look at this ECG. Clear, Shabab Banat? The regular, if it's regular, we just divide the 300 over the number of boxes between the RR complexes. Okay. Now, let's move to the next one. I'm sorry, the chat is not refreshing. Okay, so I will move to the next one, then I will go back to your chat. Now, let's take a look at this ECG. Okay. Now, do you think this is regular or irregular? Now, take a look at this, especially the rhythm strip down there. So you can see at one time it's 3 boxes, another time it's around 7, 8 boxes, then 2 boxes. Yes, thank you. It's irregular. Okay. So if we go back to our rule and we say 300 over the number of boxes, then which number of boxes will we choose? Is it the 2? Is it the 7? Is it the 4? So this rule doesn't apply if the rate is irregular. Okay. Then what can we do? Now they said, what can we do is let's go back to the manual method. I know it's maybe it takes time, but this is what we'll do. So the rule of 6 seconds. So we will count 30 boxes. And again, why 30 boxes? Because each box, each second is made of 5 boxes. Okay. So 6 seconds, 6 times 5 is 30. Okay. So in this way, we will count how many QRS complexes that we have in 6 seconds. By the way, why did we choose 6 seconds? Because simply we can multiply it by 10 and get the beats in 60 seconds. Okay, so there is nothing magical about 6 seconds. Sometimes we can do it in 3 seconds, aka 15 boxes. Then we will multiply by 20. But let's stay on the safe side. Count 30 boxes. Okay. Then after we count 30 boxes, let's count how many QRS complexes that we have here. So we have 1, 2, 3, 4, 5, 6, 7. So we have 7 QRS complexes in 6 seconds. So how many complexes or how many beats we have? Yes, thank you, Hamda. So this is 70. So simply we multiply the number of QRS complexes in 6 seconds or in 30 boxes. Then we will multiply it by 10. So again, let's apply the rule. Is the heart rate regular? No, it's irregular. The number of QRS complexes within 30 box, big box is 7. Sorry, this is not, this is by mistake. So this is times 10. Okay, I will correct it inshallah. So 7 times 10 is 70 beats per minute. Okay, now let's go to the rhythm. Now the rhythm in the heart or in the ECG, it's not just saying regular or irregular. Okay, so Mariam, actually there is, we start with the first QRS complex, okay? So we start counting, can you see the most left one, okay? So just start before it, okay? So start before it or just from the start of the ECG. But usually we start with the first QRS complex that we want to count, okay? Then now we have the rhythm. Now in the rhythm, there is one important point in the ECG that we have to comment on. Now, the rhythm here is not just saying regular or irregular. Now, the rhythm in the ECG is saying, is this sinus or asinus rhythm? Okay, and what is that? It means that is the heart electricity originating from the SA node or it's originating from somewhere else, from an abnormal area, whether it's the AV node or maybe an abnormal electrical focus. Okay, so how can we tell that? We ask a simple question. Is every QRS complex preceded by a P wave? If that is the case, if yes, then the rhythm is sinus, because we know the P wave is the result of the atrial depolarization, which originates usually from the SA node. So if we have a P wave before each and every QRS complex, then we can say this is a sinus rhythm. If that is not the case, then this is an asinus rhythm. And let's take an example. Now let's look at the rhythm strip down there. Can you appreciate the presence of a P wave before each and every QRS complex? Okay, so we have a P wave before each QRS complex, so this is a sinus rhythm. Now let's compare it to this ECG. Now look at this ECG. Sometimes we have a P wave, sometimes it's a flat line, sometimes it's something just an inverted wave. So if you look, we don't have, if you look, I mean, closely, we don't have a discrete P wave, okay? It's just, you know, an abnormal line up and down, okay? So do we have a P wave before each and every QRS complex? No. And Rita, do we start by looking? Yes, usually lead 2 is considered, we call it the rhythm strip. That's why we spread it in the bottom of the ECG. Okay, so below, look for the rhythm strip. Usually they spread lead 2 over the whole paper of the ECG. Okay, and we'll see why, because lead 2 actually it matches the heart axis. That's why it's the most, you know, evident one. So here we don't have, so we would say this rhythm is a sinus rhythm. So there is somewhere else in the heart that took the lead from the sinus node or from the SA node, and it's actually now it's making control of the heart rate and the heart rhythmicity. Okay, that's why actually if you look at this ECG, you can say that this is clearly this is an irregular ECG. Okay, so this is a case of a sinus rhythm. Now the heart axis. Now the heart axis, I don't want to go into so much details. I have put few slides for those who are interested in knowing the basics of the heart axis. Simply the heart axis will be one of three. Is it normal? Is it left axis deviation or يعني مختصر LAD, okay? Or is it right axis deviation? Now how do we know this? Now the basics are very simple of the heart axis. Now the heart axis is at the end, this is a vector of the heart electricity, and usually it points towards the apex because this is the bulkiest and yes, this is the bulkiest and has the most muscles of the heart. So usually the electricity points towards the apex. So it should be in this quadrant, and this is a normal axis. Now, if the axis deviates to the left side, okay, imagine this is a heart and you're looking, okay, you're confronting this heart, okay. So if it goes that way, then this is a left axis deviation. If it goes all the way to the other side, this is called a right axis deviation. Now, a few basics, we will take just lead 1 and lead AVF to comment about the heart axis. Okay, why are these two leads? Because they are perpendicular to each other. Can we use other leads? Yes, it will make your calculation even more precise, but clinically we don't care that much about getting the exact angle of the heart axis. Rather, we want to know if this is normal or we have left axis deviation, right axis deviation. Okay, so we will consider anything between 0 and minus 90 degrees is a normal heart rate. I know in some textbooks like Guyton they say up to minus 10 or minus 30 sometimes, but let's consider it anything in this quadrant between 0 degree, which is lead 1 is pointing at, and 90 degree, which is lead AVF is pointing at. Okay, so anything here would be normal. Now, in the ECG, we will look at the ECG and we would see if lead 1 is positive or negative, if lead AVF is positive or negative, then we will determine what is the heart axis. Okay, so what do you mean by lead 1 is positive? It says that simply the positive deflection in the the R wave, let's say, is larger than the S wave. Okay, this is simply what we mean by positive deflection. So you look at the QRS complex, and if it's mainly above the isoelectric line, then this is positive. If it's below the isoelectric line, then this is a negative deflection in the lead. Okay, so let's take all of the combinations. So if lead 1 is positive, now what does it mean if lead 1 is positive? This is simple physics, and this is vector analysis, if you remember. Of course, this is not needed from you. This is just for those who are interested. Simply, if lead 1 is positive, it means that the heart axis is going towards the direction of the lead. Okay, so this is the direction of lead 1. I'm sorry, you can't see my cursor, I know that, but look at lead 1, and there is the direction of lead 1. If it's positive, then it could be in either of these two quadrants. Now, if lead AVF is again positive, so the vector is pointing towards towards AVF. Okay, so it would be in this quadrant or that quadrant, and then we match. Where is the mutual area? It's here. You can see it by the red button. So the heart axis is in this quadrant, and it is a normal heart axis. Okay. Now let's take another example. Maybe it makes things clearer. So again, lead 1, lead AVF. Now lead 1, and this time it's negative. So the heart axis or the vector of the electricity is pointing to the opposite way of lead 1. Okay, so it's either in, let's say, the third or fourth quadrants. Okay, then lead AVF is positive, so it's pointing towards the downwards. Okay, towards lead AVF. So where is the mutual area? So it's here, and this is an area where it indicates a right axis deviation. Okay, and by the way, right axis deviation is caused by right ventricular hypertrophy simply. Okay, so the bulk of the muscle has now shifted from the apex to the right side, sometimes because of pulmonary hypertension, pulmonary valve stenosis. Okay, so you can think of so many causes leading to right ventricular hypertrophy. Okay, now the last one is if lead 1 is positive, again, so this is the area of the axis. If lead AVF is positive, is negative, then the vector is, it's opposite of lead AVF, and this what would be the axis of the heart, and this is a left axis deviation, and again it indicates left ventricular hypertrophy. We can find it in patients with severe hypertension or prolonged hypertension, and patients with aortic stenosis. Okay, so this was actually the basics, but to be simple and make things easier in the exam, we would say if both leads 1 and AVF are positive, then this is normal. If lead 1, is negative and lead AVF is positive, they say, imagine that they're shaking their hands, so they're pointing towards each other. Okay, so if they're pointing towards each other, they're shaking, and we shake with the right hand, so this is a right axis deviation. If they're away from each other, so lead 1 is positive and lead AVF is negative, then this is a left axis deviation. Okay, so this is just something quick that we use in the exam. Usually in the exam we don't have the luxury of the time to draw, vectors and get the hard access, but it's nice, if you know it. Okay, so let's go quickly to abnormalities. Now, abnormalities, I will focus now on the ST segment elevation. Then, inshallah, in the when we discuss the cases, we will discuss further, abnormalities. Now, do we have an ST segment elevation? Of course, first of all, we have to suspect this from the history. So a patient will be presenting with typical signs and symptoms of chest pain, signs of MI. Okay, so if we have ST segment elevation, then there is a myocardial infarction, which we call STEMI, or ST segment elevation myocardial infarction. You might hear this term here and there. So STEMI, it means a myocardial infarction that causes an ST segment elevation. Okay, then the next question is, after we say yes, there is an ST segment elevation, the next question is, where is this ST segment? Is it in which leads, I mean? Okay, so depending on the lead, we will say there is the location of the MI, and we will discuss this in a minute, don't worry. So this is a normal QRS complex on the right, and this is an ST segment elevation. If we recall, we said something about the J point. Okay, so this is the start of the ST segment, and it should match the isoelectric line. Now, if the J point is elevated at least 1 to 2 small boxes above the isoelectric line, then we say that this is an ST segment elevation. Okay. Now, let's take a look at this. Now, this is the leads, I call it constellation, because usually we have a rule in ECG that says one thing of anything is nothing. So if you find just ST segment elevation and just one lead, it means it has no clinical significance. So usually the ST segment elevation or abnormalities, they follow a pattern. And which pattern? The arterial pattern. So usually if the right coronary artery is occluded, then it affects the inferior side. If the left anterior descending artery is occluded, it affects the anterior. If the circumflex, it affects the lateral. So usually it follows a vascular territory. It's not random. So usually we find it in a certain constellations. Okay, so let's take a look at the limb leads on the left side of your screen. The limb leads look at the heart in a coronal section. Okay, so leads 2, 3, and AVF, they will actually look at the inferior side of the heart. Okay. Then if you look at lead, sorry. Yes. So if we go to the chest leads now the chest leads from V1 to V6, they look at the heart in a cross-sectional way. Okay. So in an axial way. So V1 and V2, they look at the heart septum. V3 and V4, they look at the anterior wall of the heart. The anterior, we mean mainly the left ventricle. And then V5 and V6, they look at the lateral wall. And if you go back to lead 1 and AVL, again, they look at the lateral wall of the heart. So now we can combine any of these two, especially the chest leads from V1 to V6. Okay, so I mean that if the patient has ST elevation from V1 through V4, so this will be an anteroseptal MI. If, let's say, from V3 to V6, this will be anterolateral. If all the way from V1 to V6, this will be anteroseptolateral. Okay, so we will just give the name depending on what are the leads that we have ST elevation in. Usually the inferior MI is by itself because it's it's a right coronary artery occlusion, and the rest will be from the left coronary artery. So let's take an example. Can you see the ST elevation and lead V1? V2, it's more evident. V3, it's very evident. V4 a little bit, and V5 now it's back to normal. Okay, so what do you think? What can we call this type of MI? Can you please tell me? Yes, thank you. Anterior wall and actually also septal because it's affecting both. Yes, thank you. So anteroseptal. So if we go back to our diagram, and is there an ST segment elevation? Yes. So this is a myocardial infarction. Where is the location? It actually affected leads V1, V2, V3, V4. So this is affecting the septal wall and affecting the anterior wall. So this is an anteroseptal myocardial infarction. Okay, now just one last exercise. Let's put everything together now. So the whole 5 points together. Now, first of all, the rate. What is this? What do you think the rate of this patient? First of all, is it regular? Yes, it looks regular. طبعا here we don't have a rhythm strip, but it looks regular from any lead that you look at. So how many boxes between each one? I think it's 3.5 or almost 4. Let's say 4. So the rate is 300 over 4. So this is 70 beats per minute. Okay. Now, is it sinus rhythm? What is the rhythm? Let's look at the P waves. So, well, Khalid, I think it's not clear, but if you take a close look, there are some small P waves. Okay, there are some small P, but I agree with you, it's not clear. But if you look at it closely, you will have P waves, inshallah. Okay, and so don't worry, inshallah. If we get you any ECG, it will be very clear. Okay, so there is a P wave, so the rhythm is sinus. Then yes, the axis. Sorry, the axis. Let's look at lead 1. Okay, so lead 1 is positive. Lead AVF is again positive. So what do you think the heart axis is? So we agree that if both positive, yes, thank you. It's both positive, so normal axis. Now, what are the abnormalities that we can find with this patient? So please don't get confused, because this ECG will follow a history of a patient with chest pain. So when you look at the ECG, your mind will be directed towards looking for signs of ischemia or infarction. Now, so let's look at leads 2, 3, and AVF. So if you find any one of these 3 leads is elevated, please look at the other 2, because as we agree, this is a constellation. So lead 2 will not be elevated by itself. It has to follow lead 3 and lead AVF. So all of them are elevated. So this is what's known as, yes, thank you. So this is an inferior. So the description would be, you have to describe. So you should say ST segment elevation in leads 2, 3, and AVF. My diagnosis is inferior wall MI or just inferior MI. Okay. So yes, thank you, Lanya and all. Now, if you see the other side, I didn't mention it, but if you see there is ST segment depression in leads V1, V2, V3. Now, please don't get confused, because ST depression is a sign of ischemia, not sign of infarction. Okay, and this is what happens when we have an MI. There is a term called reciprocal changes. Just keep it in your mind. You might hear it here and there. Reciprocal changes, it means that the heart, usually it tries to compensate for the occluded area. So it actually, physiologically, the body causes vasoconstriction in the other leads in order to direct the blood flow to the infarcted area. That's why we have signs of ischemia in other leads. Okay, so if you look at the anterior and the septal leads, they show ST depression, and this is a sign of ischemia. Okay, but of course it will not lead to infarction, because this is a physiological event. But this is again one of the signs of MI. Okay, no, not chronic ischemia. This is a sign of this is something acute. Okay, we look for this is what we look for in patients with acute MI, and this is what we look for patients where we ask them to do the stress test. Okay, so once they have ST depression, then we stop the machine. I don't know if you have seen it. Okay, so ST depression is a sign of ischemia. If we don't act quickly, it might evolve into ST elevation and MI. Now, yes, I agree with you, Shahad. V5 and V6, they look like they have a bit of ST segment elevation. I totally agree with you, and thank you for noticing that. Please note that in the exam we will get you something clear and not confusing. Okay, but yes, I agree with you. although there is one point that's worth mentioning here, and the limb bleeds, if you have just one small square of elevation, it's significant, while in the chest lead, it has to be two. That's why I didn't mention it. So it actually in the chest lead has to be more than two. Yes, Khalid, I agree with you. So it has to be more than two small squares, okay, in the chest leads. So don't bother yourself about these details. Just look at the most evident one. The most evident one, as you see, it is in leads 2, 3, and IVF. Okay, so I hope this was clear. Thank you so much for listening. And now we will go back, inshallah, with Dr. Mana to review the other cases. Okay, thank you so much.